Universitas Diponegoro, Undip, is one of the oldest public universities in Indonesia, established on January 9, 1957, located in Semarang, Central Java, Indonesia. Since the enactment of the Government Regulation Number 52 of 2015, the status of Undip is legal entity state university.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Greeting for University Diponegoro, the best university in Indonesia. Universitas Diponegoro, as one of the universities in Indonesia, has declared to be research university with an international reputation in accordance with the vision of become an excellent research university. As an international world-class research university, although UNIF is expected to have a good academic reputation that create globally competitive graduates with excellent competence, conduct continuous research and development for the people with continuous improvement of human resources by international standard capacity development program.
Internationally, Undip has ranked by the QS World University Ranking and Times Higher Education World University Ranking as the top 8 best universities in Indonesia. Undip was ranked in the 2021 QS Asian University Ranking, University Graduate Employability at 2020 QS World Ranking, and in the 2021 QS World University Ranking by subject for Business and Management Studies. Moreover, Undip also ranked by Times Higher Education World University Ranking for Times Higher Education Impact Ranking, and Times Higher Education World University Ranking by subjects for Business and Economic, Life Science, Physical Science, and Engineering and Technology. For environmental sustainability, UI Green Metric also posted Undip at 39th World University Rankings. Undip has a strong commitment to improving the quality of education towards global standards by continuously improving the quality of education for its students, increasing the quantity and quality of research and scientific publications, and contributing to society through community services. Strategic planning and efforts being implemented to internationalize Undip is by opening international class programs in various study programs, allocating scholarship opportunities for applicants from abroad through the Diponegoro Master Scholarship or DIS program, and Diponegoro Exchange Experience Program or DEEP, cooperating with leading universities in the world concerning education collaboration, such as facilitating Undip students to study abroad and vice versa. Faculty of Law has developed with the improvement of the education system, the increase in number and quality of teaching staff, lecturers, as well as the increasing number of facilities and infrastructure supporting the education. Faculty of Economics and Business, the faculty which has an international undergraduate program and Bloomberg collaboratory facilities, was ranked 501, 550 in QS World University Ranking by Subject 2021. Faculty of Engineering also a home for research center such as Membrane Research Center and Center for Biomechanics, Biomaterial, Biomechatronics, and Biosignal Processing. Faculty of Medicine is one of the best faculties at Universitas Diponegoro. Faculty of Medicine has complete laboratories which support the student practicum. Faculty of Medicine also become the important part of the establishment of Rumah Sakit Nasional Diponegoro, RSND, or Diponegoro National Hospital that belongs to Universitas Diponegoro. Faculty of Animal and Agricultural Science has transformed through sustainable concept and digitalization by the development of digital farming and sustainable livestock. Faculty of Humanities consists of several study programs, include literature, language, history, anthropology, libraries, philosophy, and archives. It has several language centers such as Indonesian, English, and Japanese, the Indonesian History Research Center, and Local Culture Preservation Research Center. Faculty of Social Science and Political Science. It has the International Relations Study Program that is well known amongst prospective students, whereas the Communication Study Program emphasizes collaborations with local and national mass media to channel the student talents by directly practicing it. Faculty of Science and Mathematics is a home for several research centers such as Center for Plasma Research that focus on the plasma application and Center of Marine Ecology, Biomonitoring, and Sustainable Aquaculture that covers a various aspects of marine ecology. Faculty of Public Health aims to create graduates with good competency and skills in the public health. It's supported by academic and research activities that are intensively conducted in the area of occupational health and safety area, health promotion, stunting, and many others. The Faculty of Fisheries and Marine Science has vision to become an excellent faculty in the field of fisheries and marine tropical by 2024. It becomes the center for education, research, and community development for the coastal region. It has Center for Coastal Disaster Mitigation and Rehabilitation Studies and Natural Laboratory for Fishery Study, Marine Conservation, and Biodiversity, as well as Disaster Mitigation and Coastal Management and Rehabilitation. Faculty of Psychology Universitas Diponegoro also provides international exposure in the form of student exchange and summer course programs. School of Postgraduate Studies was established in order to respond to the global challenge with a multi- and interdisciplinary approach. In Vocational School Universitas Diponegoro, the students were educated with curriculums that is in line with the industrial needs. Apart from that, the vocational school equipped with certified smart green building that use renewable energy as a power source along with water and wastewater treatment system for the water resources. Supporting the vision to become an excellent research university, Undip established the Laboratory Center with high-tech equipment, several research centers in the field of medicine, food technology, water and wastewater treatment, renewable energy development, health supporting technology, advanced material engineering, culture preservation, sustainable development, and established Marine Science Technopark for research and technology development in the field of marine and fisheries, and the incubation for the startup business, which is open for international and domestic student internship. Undip has various supporting facilities to provide excellent services in education as well as research. International collaboration with hundreds overseas top-ranked universities has established to support internationalization in research, academic, and community services programs.
Undip, undip, undip.
Program Studi Doktor Ilmu Kesehatan Masyarakat atau PSDKM, Fakultas Kesehatan Masyarakat Universitas Diponegoro, didirikan berdasarkan Surat Keputusan Menteri Pendidikan dan Kebudayaan Republik Indonesia Nomor 460-E-O-2014. Pada tahun 2018, sesuai dengan keputusan Rektor Undip nomor 678-UN7.P-HK-2018 tanggal 25 Juli 2018, nama Doktor Ilmu Kesehatan Masyarakat atau DIKM diubah menjadi Doktor Kesehatan Masyarakat atau DKM.
Visi kami adalah menjadi lembaga penyelenggara pendidikan doktor di bidang kesehatan masyarakat yang unggul pada tataran internasional pada tahun 2024.
Penyelenggaraan pendidikan mahasiswa angkatan pertama dimulai bulan September tahun 2014. Mulai tahun akademik 2020 hingga sekarang, PSDKM FKM Undip mengembangkan program doktor menjadi 2 program doktor, yaitu Doktor Kesmas by Course dan by Research. PSDKM menerima mahasiswa baru melalui ujian mandiri. Penerimaan mahasiswa baru pada prodi DKM menganut azas independensi, transparansi, accountability, responsibility, fairness, serta dilakukan secara objektif berdasarkan kriteria yang telah ditetapkan untuk menjamin kualitas input calon mahasiswa dengan mekanisme seleksi ketat yang harus diikuti oleh calon mahasiswa berupa tes potensi akademik atau TPA, tes bahasa Inggris, dan tes substansi atau materi keilmuan kesehatan masyarakat berupa tes substansi tulis dan wawancara, dan yang terpenting serta utama adalah kewajiban mengikuti tes psikologi. Latar belakang mahasiswa PSDKM FKM Undip berasal dari akademisi, birokrat, praktisi, dan lain sebagainya. Proses pembelajaran dilaksanakan dengan metode SCL dengan menitik beratkan pada critical appraisal yang didukung oleh fasilitas berupa sistem informasi untuk pembelajaran, akses internet, akses e-jurnal, perpustakaan, dan ruang baca, serta ruang diskusi. Semua mahasiswa PSDKM memiliki akun Single Sign-On atau SSO Undip yang dapat digunakan untuk mengakses jadwal pembelajaran, presensi, nilai hasil akademis, akses materi perkuliahan, hingga mengakses jurnal internasional bereputasi. Proses akademik di PSDKM FKM Undip meliputi pertemuan ilmiah berkala atau forum diskusi ilmiah, bimbingan, klinik manuskrip, ujian baik daring maupun luring, serta international conference. Dalam mewujudkan proses tersebut, PSDKM FKM Undip didukung oleh dosen yang telah terkualifikasi guru besar dan S3, telah tersertifikasi, memiliki pengalaman riset, dan pengalaman publikasi jurnal internasional Q1. PSDKM FKM Undip juga didukung dengan fasilitas akses database jurnal internasional bereputasi untuk mendukung kegiatan akademik. Selain itu, juga didukung dengan tersedianya manuskrip digital, hasil tugas akhir yang dapat diakses secara online. Demikian halnya, akses referensi berupa artikel dan proceeding dari penyedia database jurnal terkemuka, baik level nasional hingga internasional. Penghargaan yang berhasil diraih oleh mahasiswa PSDKM FKM Undip diantaranya adalah terpilihnya sebagai narasumber dalam berbagai acara bergengsi, mendapatkan predikat Best Presenter dalam International Conference, publikasi dalam jurnal Q1, dan menghasilkan beberapa karya hebat seperti buku dan produk lainnya yang mendapatkan haki. Lulusan PSDKM FKM Undip mengalami peningkatan karir yang luar biasa, seperti diantaranya menjadi Direktur Poltekkes, Direktur Stikes, Ketua Jurusan Poltekkes, Kepala Badan Perencanaan dan Pengembangan Universitas Swasta, narasumber pelatihan dan webinar, Ketua Bagian Universitas Negeri, reviewer jurnal, dan lain-lain.
Selamat bergabung dengan program studi Doktor Kesehatan Masyarakat, Fakultas Kesehatan Masyarakat, Universitas Diponegoro.
Program Studi Magister Promosi Kesehatan Fakultas Kesehatan Masyarakat Universitas Diponegoro Semarang menjadi suatu institusi terkemuka, perintis dan pelopor dalam pengembangan dan penyebarluasan teknologi dan pelayanan di bidang promosi kesehatan.
Halo, sekarang kita ada di kampus FKM Undip Semarang.
Dan kita akan membawa kalian mengenal lebih jauh program studi Magister Promosi Kesehatan.
Berdiri pada tahun 2001, Program Studi Magister Promosi Kesehatan Fakultas Kesehatan Masyarakat Universitas Diponegoro menjadi satu-satunya Magister Promosi Kesehatan di Indonesia. Pada tahun 2019 memperoleh akreditasi A atau Excellent dari Lembaga Akreditasi Mandiri Perguruan Tinggi Kesehatan.
Proses pembelajaran di program studi Magister Promosi Kesehatan dilakukan melalui ceramah, diskusi, penugasan, praktikum laboratorium, dan lapangan. Mahasiswa juga dituntut untuk berperan aktif dalam proses pembelajaran dengan menggali informasi dari sumber-sumber lain seperti jurnal ilmiah, internet, media massa, dan kegiatan-kegiatan ilmiah di dalam maupun luar negeri.
Selain itu, mahasiswa juga dibekali dengan pelatihan-pelatihan kompetensi yang sangat dibutuhkan di dunia kerja, seperti pelatihan konselor, penulisan artikel publikasi, desain media, ahli hygiene dan K3, dan banyak lainnya. Nah, di sini setiap mahasiswa dapat memanfaatkan fasilitas yang telah disediakan oleh fakultas dan universitas seperti ruang kelas yang nyaman, laboratorium dalam dan luar ruangan, masjid kampus, jurnal online, perpustakaan, poliklinik, sarana olahraga, dan lainnya. Jadi, pasti kalian akan bersemangat kuliah di sini.
Kegiatan praktek lapangan atau residensi menjadi salah satu kegiatan wajib bagi mahasiswa untuk menerapkan keilmuan yang telah didapatkan di perkuliahan untuk membantu menyelesaikan permasalahan kesehatan di masyarakat.
Kamu bukan lulusan bidang kesehatan, tapi pengen kuliah di sini.
Tenang, jangan khawatir, karena kalian semua bisa jadi mahasiswa di program studi Magister Promosi Kesehatan FKM Undip Semarang ini. Bahkan dari D4 juga bisa loh.
Buka bagi semua disiplin ilmu yang ingin mengembangkan karir dan minat di bidang kesehatan.
Belajar tentang teknologi dan media promosi kesehatan.
Mudahan fasilitas untuk mengikuti kegiatan non-akademis.
Kurikulum yang dirancang untuk menyelesaikan studi dalam waktu 3 semester.
Biaya pendidikan yang terjangkau.
Tenaga pendidik yang berpengalaman dan ahli di bidangnya.
Bisa belajar mengenai health promotion yang ada di luar negeri melalui program residensi.
Menghasilkan tenaga promosi kesehatan yang mampu mengidentifikasi dan juga merumuskan masalah secara tepat mengenai perilaku beresiko kesehatan.
Kak, spill dong kerjanya sekarang apa? Kan alumni dari sini, ya enggak?
Hai, saya Osano Varian, saya asli Semarang. Saya masuk di Magister Promosi Kesehatan tahun 2017. Saat ini saya bekerja di PT Freeport Indonesia di Divisi Operasi Tambang Bawah Tanah sebagai Safety Assurance and Compliance. Perkuliahan di Magister Promosi Kesehatan sangat seru, tempat perkuliahannya sangat nyaman, dosen-dosennya sangat profesional, dan komunikatif serta inspiratif. Terima kasih Magister Promosi Kesehatan, saya akan ikut berpartisipasi dalam meningkatkan derajat kesehatan, khususnya pada pekerja di sektor industri pertambangan.
Saya Kurnia Ramadhani, asal Probolinggo. Saya masuk di Magister Promosi Kesehatan FKM Undip tahun 2011 dan lulus tahun 2013. Manfaat yang saya rasakan selama belajar di sana, yang pertama, saya merasa terbiasa dengan metode pembelajaran internasional. Yang kedua, melalui praktek lapangan, merupakan bekal implementasi di dunia kerja. Yang ketiga, program mendukung skill improvement melalui pelatihan dan seminar.
Dengan metode perkuliahan dan kualitas kurikulum kami yang relevan dengan kebutuhan di lapangan, terbukti lulusan program Magister Promosi Kesehatan FKM Undip Semarang dapat memiliki kompetensi sebagai manajer, edukator atau dosen, konsultan dan peliti pada bidang promosi kesehatan, dan dapat bekerja pada semua bidang pekerjaan, baik di instansi pemerintah maupun swasta.
Nah kan, masa depan kalian ada di sini.
Tunggu apa lagi? Selamat datang di program studi Magister Promosi Kesehatan Fakultas Kesehatan Masyarakat Universitas Diponegoro, Semarang.
Okay. Good morning, ladies and gentlemen. We have a visiting professor today with Mr. Muhammad Sakadan Mia with the topic research strategies and challenge to improvement in maternal and child health and family planning. For today's session, we have heard to Mr. Budiono as Dean of Faculty of Public Health, Universitas Diponegoro. Good morning, Mr. Budiono. Okay, by waiting with Mr. Budiono, I have to give a little speech. Yeah, the Honorable Mr. Budiono as the Dean of Faculty of Public Health, Universitas Diponegoro, and then Mr. Muhammad Sakadan Mia as the main speaker at today's visiting professor session. Colleagues, lecturers, students, and all participants of today's Zoom meeting, good morning and welcome to the Research Strategies and Challenge to Improvement in Maternal and Child Health and Family Planning event. We will learn a lot with Assistant Professor Mr. Muhammad Sakadan Mia, PhD. He's from Department of Anthropology, Shah Jalal University of Science and Technology, Bangladesh. I hope that we can all benefit a lot from studying with Mr. Sakadan. Hopefully, we can enrich our knowledge, especially related to the topic of men involvement in maternal and child health and family planning. I'd like to express my gratitude that you all, the people who have organized this event, congratulations on joining the visiting professor this morning via Zoom meeting, and don't forget to prepare notes and questions for this event. Again, thank you very much for joining this session. Salam sehat. For the next session, we hope the Honorable Mr. Budiono as the Dean of Faculty of Public Health, Universitas Diponegoro, will give the speech. Good morning, Mr. Budiono.
Ya, assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you very much, Pak Samsul, as head of study program of health promotion, Magister of Health Promotion. I'm sorry, I have to change our background. Wait a moment. Oke. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much. Assistant Professor Sakadan Mia from Bangladesh. Thank you very much for joining this seminar. And also the participant, especially for our student from undergraduate student, also magister of health promotion and also doctoral program of the public health in Faculty of Public Health Universitas Diponegoro. Thank you very much. This topic I think very important to us, research strategies and challenge involvement men in maternal and child health program and also family planning. We know that the men are in Indonesia, especially for the head of the household, have an important role to make a decision in the family. For example, for delivering the baby from the pregnant woman, and also need supporting from the man. In this case, is the head of household. And also the other programs also involve the man to support the family or the community in area of health program. For example, for immunization also has the role of the man. So this I think Assistant Professor Sagahan Maya will give a lecturing with the brief explanation about the how research strategies and how to involve men in a maternal and child health program and also family planning program. So I think he has so many knowledge and experience in this field. So I hope the participant will active discuss to know more about this topic. Thank you very much. I hope this will useful for us, especially for our students, to increase knowledge and also experience. Thank you very much. With your permission and of course Allah Subhanahu wa Ta'ala, with the Bismillahirrahmanirrahim, this event I officially open. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Mr. Budiono. After the speech from Mr. Dean, Pak Budiono, we will listen to the presentation from Mr. Saganan Mi'ah. Good morning, Mr. Saganan.
Good morning.
Assalamualaikum
warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. I will be assisted by Faiza Fadila as the co-moderator, and I hope today's event will go well. Please, Mr. Saganan, to start your presentation. Time is yours.
Okay. Thank you, Professor Shamsul Huda, and very good morning to everyone. Special thanks to the Dean Faculty of Public Health, Associate Professor Dr. Budiono, and Professor Dr. Shamsul Huda, and the inviter Jahru, Professor Dr. Jahru, and all the honorable faculty member, distinguished participants. Assalamualaikum and very good morning. And I am Dr. Muhammad Shahjahan Mia, MD means Muhammad Shahjahan Mia, and I'm welcoming to participate this lecture. The Dean says that I'm experienced, but I think I'm still learning in this field. And I will share just a few experiences with you, and some summary of the secondary literature also. So I want to start presentation. So the slide will share by me or the PowerPoint slides.
You can share.
Okay, but the screen share screen is option by one participant can share.
Oh.
So here
Mbak Dita bisa bantu atau siapa Pak Samsul?
Okay.
Okay. Yeah. Sorry.
Prof. Sahgahan, I'm sorry, I have to move to another room to open the seminar too. So I have to leave this room. Sorry, hopefully this will success.
Okay. Okay, now I can see. This one. So the today's title topic is the research strategies and challenges to involve men in maternal child health and family planning. Thank you to the Faculty of Public Health, University Diponegoro, Indonesia, for arranging this event, and I am delighted and honored to have this platform to say and sharing some experiences. Could you please second? Okay. Today's presentation I divided into 4 parts. First, some background information about maternal mortality rate, child mortality, and family planning. Then strategies, what kind of strategies have been taken to reduce this MMR and child mortality. Here I include the Millennium Development Goal, very briefly, Sustainable Development Goal, ending preventive maternal mortality, and your country's one local is Siaga strategies like in Indonesia, from and 5 coverage targets that included by the EPMM and advancing the maternal health. Then there are 10 milestones also included there, and challenges of involving men in maternal child health and family planning, and thereafter some research strategies that very briefly I will share, and some recommendations from secondary sources. Here we already all that the scenario of the maternal mortality, child mortality, the global situations, and here's some just briefing. Around 800 women died every day, causes that are related to pregnancy and childbirth, and every 2 minutes there one mother died, and almost 95% of all maternal deaths occurs in low and lower middle income countries. And child mortality here, around 5 million children died every year. Those are under 5, and among these 2.4 million died in newborn stage in the first 28 days of life, and the leading causes of these deaths are preterm birth complications, birth trauma, pneumonia, diarrhea, and malaria. And all these maternal and child mortality is are preventable, and the conditions and diseases are associated with lack of quality care. Only for this, and those there are many strategies have been implemented and still are ongoing. Some progresses are noticeable here, like from 1990 to 2015, and then 2020 is remarkable change, progress in maternal and child mortality and even family planning. Here WHO 2020 they shows that the maternal mortality ratio dropped by 34% worldwide. The number is 342 to 223 deaths per 100,000 live births, and the global under 5 mortality rate also fell down to 37 deaths per 1,000 live births, and under 5 mortality is declining faster. If you compare then the neonatal mortality is still high in many countries, in most of countries. And the Sustainable Development Goal 3.1 sets out that by 2030, the global maternal mortality rate is reduced to less than 70, and every country is already developed countries achieved, but the underdeveloped and low and middle income countries is still high rate. And the target is also said that no country should have an maternal mortality rate more than 140 per 100,000 live births. And for family planning method, there SDG, the Sustainable Development Goal Indicator 3.7.1, that their proportion of women of reproductive age, aged 15 to 49 years, who have their need for family planning satisfied with the modern methods. And there are out of 1.9 billion women in this 15 to 49 years age group worldwide, 1.1 billion have a need for family planning. And out of this 1.1 billion women, 842 million are using contraceptive methods, whereas 270 million have an unmet needs for contraception in 2019. There is a huge number that are still not using these contraceptions, and only one contraceptive method like condoms can prevent both pregnancy and the transmission of sexuality infections, including HIV/AIDS and AIDS. The use of contraception advances the human right also of people to determine the number and spacing of their children. And already some success that 23 million adolescent, 76,000 maternal deaths could be avoided each year by using modern contraceptions. And there are 23 million adolescents do not have access to the modern contraceptions. And in 2017, use of modern contraceptives prevented an estimated 308 million unintended pregnancies. So the global scenario of maternal mortality and the disparities. Although Millennium Development Goal have some successes, but still Sustainable Development Goal need to target to reduce this maternal mortality. We already discussed the 70 and the 100, not more than 140 per 100,000 live births, but still they are high in most African countries and Asian, Southeast Asian, and Pacific also, and some Latin Americans. And the success rate is higher for the developed countries, high income countries, that we can see the disparities in this bar diagram. There, the high income countries like Europe, Northern America, and Atlantic, New Zealand, these are very high success, but whereas the Sub-Saharan Africa, Northern Africa, Western Asia, Eastern, this part are still high risk areas, and with dangers for this maternal mortality and even child mortality. And the top 10 countries with the highest number of deaths are here. You know, the Nigeria, the highest, India, Pakistan, Democratic Republic of Congo, Ethiopia, China, Indonesia, United Republic of Tanzania, Angola, and Bangladesh. Also, the highest number of deaths for children under 5 years. Now we have see the scenario of the global scenario of family planning, maternal mortality, and child mortality. But what have been taken to reduce this mortality? Globally, from first the Millennium Development Goal target they set by 2015. We already know that although they have some successes, but still unfulfilled to reduce the rate. Target was 75%. 300, it was 380, but it was achieved 45%, 210 per 100,000 live births. And MDG 5 called for universal access to reproductive health for all women, including the antenatal care coverage, contraceptive prevalence, unmet family planning need, and adolescent birth rate by 2015. And in 2015 also there are another strategies, ending preventable maternal mortality launched to improve maternal health and well-being and achieve the parallel with the sustainable development goal for reducing the MMR. And the sustainable development goal global target is an maternal mortality rate of less than 70. We already discussed in past, the per 100,000 live births by 2030, and no country should be greater than the 140. And the target requires the holistic human rights-based approach to sexual, reproductive, maternal, and newborn health. So this is the valuable strategies for ensuring and to reduce the maternal mortality and child mortality, and even the family planning, because the strategy or the planning policy and the program will not achieve if the target would be the holistic, and that will not address the human rights issues for even from sexual to reproductive, maternal, and newborn health. And the target needs health system strengthening as well, that will support the effective implementation for universal health coverage. And the newborn mortality at least should also, sorry, I missed this one. The newborn mortality rate target is at least as low as 12 for the newborn, and under 5 mortality would be the 25 per 1,000 live births in every country. So this is the strategies. Next slide, please. Next. Sorry. And according to the ending preventable maternal mortality principles, the target I see included this, for they adopted some important issues to reduce the MMR under 5 child mortality and the family planning, because they have not only principles, they also some cross-cutting actions and strategic objectives. These are like guiding principles: empower women, girls, and communities. That without empowering these, the program will not, the target will not be achieved, not possible. And the protect and support the mother baby reared together, not a single health. It's not the mother or baby separate health. It should be interlinked. And ensure country ownership, leadership, and the supportive legal, regulatory, and financial framework also, and apply human rights framework to ensure the high quality reproductive, maternal, and newborn health care. And here is the services should be available, accessible, and acceptable to all who need it. We already know the access theory and models. According to that, if the program is not available or accessible or acceptable, that would not be sustained or successful. And there are some cross-cutting actions also included here, that improve metrics, measurement systems, data quality to ensure that all maternal and newborn deaths are counted, and allocate the educate resource, financial issues, and effective healthcare financing. And the 5 strategic objectives here also included, that are address inequalities to access to and quality of sexual, reproductive, maternal, newborn health care, ensure universal health coverage for comprehensive sexual, reproductive, maternal, and newborn health care, and address all causes of maternal mortality, reproductive, and maternal morbidities and related disabilities. And strengthening, you all, I'm just reading this one because you will find these issues in the secondary document. the strengthen health systems to respond to the needs and priorities of women and girls, and ensure the accountability to improve quality of care and equity. And the 5 coverage targets also here included, that are every target 1 is every pregnant woman, and it's not only preventive mother, as newborn also, and included newborn them, and indicator for 4 or more antenatal care contacts. Global targets is 90% global coverage of 4 or more antenatal care contacts, and national target is 90% of countries have 70% less, and sub-national target is 80% of districts, and the target 2 is every birth that should be included, births attendance by skilled health personnel. Our global target is 90%, and national target 90%, and sub-national also 80%. And the target 3 is every woman and newborn. Here's the every routine postnatal care within the 2 days. The target is same. So these targets have in many countries they have these strategies and plan included health policy, but there are still limitations about the health shortage of health workforce and the system services. If we consider the building blocks of health systems that are still need to be resilient to achieve this target. Next. Target 4 here, the every pregnant woman and with the obstetric complications, that proportion of population covered by emergency obstetric care health facilities within 2 hours of travel time. The global target at least 60% of the population able to physically access to closest emergency obstetric care health facility within 2 hours of travel time. And national target is 80% countries. But in case of those countries, I already mentioned that the lower and middle income countries, especially Southeast Asia, Southeast Asia, and the Pacific, and the South African and some Latin American countries, they have they cannot because of their the systems and the workforce shortages. And the target 5 is also the on broader determinants of maternal health. The proportion of women aged under aged 15 to 49 who make their own informed and empowered decisions regarding sexual relations, contraceptive use, and reproductive health care. So this indicator or the target should be our main focus, where we the public health specialist, public health worker, and the researcher can do focus on their areas, because if the women cannot decide their contraceptive use or empowered about their sexual relations and the reproductive health care, that implies for the these decisions not only by the women, also not only single women 15 to 49 years is the decision, and the process is controlled or surrounded by the surrounded, because the male partner, not only for the male partner, even in the male family members for the adolescents, and for the mother, the pregnant or the married, their husband or male partners should be supported. And this how this support should be implemented. There some I will discuss in some next slides, that the issues why male engagement are challenges. But we can focus here our research strategies, like some here I included also, but I shared in this point that the study already conducted some quantitative, some qualitative, that are not, I think that the holistic, the target millennium goal principles, that was not kind of holistic. The research methods are not maybe not appropriate for understanding this, because if these research are conducted participatory or more active, the target will achieve more frequently or easily. So these issues should be our main focus. So next slide, please. I'll discuss this in broader our challenges slides. And there are also some 10 milestones towards advancing maternal health are proposed by the ending preventable maternal mortality. There are some milestones that should be from global to national to subnational. Here the milestones are policies and plans, quality of care, equity, data for action, investment, health workforce, response and resilience, commodities, accountability, research, innovation, and knowledge exchange. I'm sorry. So here, if we see this, without we are implementing one single or 5 or 6 or even 9 without research or innovation, that should not be maybe sustained, because our behavior, our culture, our people and our systems, everything is always changing, and is context specific. The African context, the South Asian context, and Pacific context, and the Latin American context are different. So every country, subnational, from national to subnational, that should be focused, and they're based on focused on the considering the context of the local context, the people needs. So without research and innovation and knowledge exchange, the program should not be sustained. And here the achieving milestones, then to achieving the EPMM coverage targets, then it will be achieving the improved maternal and perinatal health outcomes that will contribute to the achieving to achieve the sustainable development goals and other global targets like universal health coverage, other things. So this framework should be focused. And no, it's okay. Thank you. And I focus, there are some from Millennium Development Goal, Sustainable Development Goal, and ending preventable maternal mortality, and some milestones there. And you know already the Indonesian context, there are also some maternal mortality, also some reduces this issue. This one in another slide, the top 10 countries, there the rate is slower than this one, because this data is 359 is 2013, and it's 10 to 15% pregnant and postpartum women experiences depression here, and women experiences positive, stable, and secure relationship with her spouse, have better able to cope with the stress, adopt positive and health practices to improve her well-being. Siaga campaign, I included this only for Siaga campaign into our next slide, and this one here, the support should be instrumental, emotional, and informational, because if the spouse do not take according to your Siaga, do not take into the hospital, or the preparation instrumental issues have not well prepared, the campaign will not be successful. And the support, if the spouse arranges everything, including financial and the transport vehicle, but to the facility center, but he is not cooperative, and support is not emotional, will not be successful. And the information also, the wife or the mother is not knowledgeable about the services, about the facilities, she will not go visit the facility center, or she will not play the rules, follow the rules of the maternal or child health issues. And the study already found that positive spousal relationship, degree of husband's involvement in pregnancy and childbirth, determines the healthy maternal behavior and well-being by reducing the distress. And in Indonesian context, another Sokono in 2022, the regional disparities in Indonesian context are found this into this husband support and male involvement engagement in context of Indonesia. Next slide, please. And Siaga campaign, you already better know than me that here the SIAP means that a husband with pregnant wife should always be ready to help and prepare for any complications that might arise, such as ensuring there is sufficient money for healthcare and preparing for blood donations. And Antar refers to always take the wife to visit health professional whenever necessary or transport her to access healthcare. And Jaga means to always guard and support the wife, make sure she has proper rest as well as proper nutrition, and help her to identify any danger signs. So this campaign is, I think I found among the many of the policies, strategies. So this one, if can implement it properly, participatory way, because if the husband, not only the male in engagement, the decision is also other family members as well, like in mother-in-law, father-in-law, and other even for unmarried women, unmarried adolescents, or the women, their male members also decided to visit for visiting the healthcare. So every surrounded by the women or adolescent girl should be included participatory in this campaign to ensure the better health and well-being for the mother and children. So next slide. Now we want to move the challenges of involving men in maternal and family planning. What are the challenges? Many studies already done about challenges of involving men in maternal child health and even separate family planning. These studies are mostly individual. Very few studies conducted in mixed method way. The findings are here. I try to show briefly here. The perceptions. Most of the study findings, like TL 2019, that says the limited understanding about the involvement, responsibilities, and misunderstanding also about the side effects of the birth reproductive technologies or birth control technologies. And some socio-cultural barriers. The most significant one is the attitudes, the male dominance in relationships, and physical abuse and social norms might make it harder for men to take. The attitude is still not cooperated, and the dominance, patriarchal society that also dominates the male in their relationships, whether the contraceptives will be used or whether the mother will go visit for the ANC. That are controlled by the male, and male, not only husband, or that also by the father-in-law, the household head, even in the mother-in-law, some and the relationships as well, and the abuse, but physically abuse, and the social norms. These are not still addressed well in our research in these issues. And the traditional gender roles already, that the men may not assist because they assume that these issues are women's responsibility. The birth control pill, the most of the even the global situation, the reproductive technologies are mostly focused on the women body, not for very few recently changed except the condom. The rest are only for the female centric. So gender roles, the male perceive that these are female responsibility, women responsibility, and absence of male friendly services. Those who are many studies found that the educated, the service holder, and the urban living people are supportive and cooperative for for supporting their female partner to visit or contraception family planning use, but still those who want to visit, the service providers are not friendly to the for the male, and most male friendly services that meet men's requirements in safe and welcoming setting are very needed here to address these issues. And lack of male participation in policy making also, and the policy making here women dominate the maternal child health and family. Still I don't know about the Indonesian context. In context of Bangladesh, these issues are only for female part, and female family planning policy making that resulting policies that don't meet men's demand without if you include and exclude like male dominance, they are excluding the female, and the policy level, if the women are there, if they exclude the male, that policy should not be participatory or sustainable policy for the effective policy for program implementation. And the male participation in policy making is badly needed to address their distinct requirements. And there are also another challenges is sorry, the male role models. So those who are already supporting like some role model, like maybe the icon person or idol person in a country, that should be the health professional or the cinema people, media people, or any kind of the role models should be publicized or to present to the others. And those are like urban peoples are more supportive, then urban role model people can visit it to the rural areas to encouraging them for more participation. And the another vital one is the stigma and discrimination. Still many male study already identified that male are supportive minded, but they cannot support, they cannot visit to the women with the women to the visiting health facility center. In context of Southeast Asia, like UN Women Report 2014, that 47% women cannot decide alone to visit to the health facility center. So without male partner or the other family member support, accompany to the visiting center, it would not be fruitful. So male, they wanted to support or participate, but the social stigma, someone participated, their friends, oh yes, they say, oh, you are going to support your friend, your wife. So this kind of stigma, social stigma, also influences for not participating into the male involvement in maternal child health and family planning. So, slide please. Some experiences in context of Bangladesh, one study, their male involvement. I just in the semi-urban areas, this study conducted. I took the three qualitative quotation here. One male respondent that it is becoming our culture. If my friends see me take my wife to the clinic, he will say me as a henpecked. But we should come out of this social stigma. All of us should treat reproductive health issues as meant for both husband and wife. And another male respondent there, I observed my wife from the very beginning of our marriage and realized that she is not able enough to take any family planning method. I was afraid that any female-centered contraceptive method might increase her health complications and might be a great risk for her health. Then I told her, don't worry, I will adopt one of the effective methods for me. You just stay healthy and safe. That's what I want. And the female, I think it is obvious for a husband to be self-interested to get him involved in reproductive health issues actively. He has to come forward from his own interest, because the wife, the newborn, is not only their health, it's the holistic health of family. So self-interest should be the another way to ensure the participate. Some next slide. And engaging men and boys, the EPMM strategy, they mention these 4 steps in the strategic planning guide. The step 1 is define the behavioral aim of your initiative. Is very important before implementing, because what we are going for home, and what is about their behavior, because every single person's behavior is context specific. Like if we consider that the disparities of the maternal child health mortality, that not only global, their disparities is also within the countries, within the regions. So because of these behavioral differences, so some maybe rural, urban, education, non-educated, non-educated, this way we should be focused or defined before implementing any strategies. And step 2 is assess men's and boys' knowledge and attitudes related to reproduction and contraception from the family member to school and other institutions. The boys and men's knowledge should be improved. And another one is the assess how gender norms affect male engagement in family planning. Gender norms, we already discussed that gender norms is greatly influenced, because it's the responsibility of male or female. So it's not the male or female, it's holistic, it's both participatory, dyad. And that step 4 is identify the programming approaches that engage men and boys. Both men and boys should be engaged for in program implementation approaches. The next slide, please. Here the strategies, the second focus, the research strategies of challenges. So I didn't go for the table, the number of studies. I downloaded around 21 studies. Some mostly are African context, some Indonesian, some Asian in India, some Pakistan, and 2 papers from Bangladesh that are focusing. And most of these studies are only quantitative and very few qualitative. In Ghana, Nigeria, Tanzania, and Bangladesh context, I found these are qualitative studies. So only one, the research strategies, that is it possible to explore the realities, because we are searching the social realities in our social field, not in our natural field like other physics, chemistry. So this social world is complex in context of the peoples, in context of the religion, in context of the beliefs, and in context of the cultural issues and regional issues. So the study only single quantitative or only single the qualitative, is it possible to explore? Like for the qualitative, we are adopting or conducting the in-depth interviews, screen-forming interviews, focus group discussions, and some observations. And for the quantitative, survey methods. So in this way, can we explore the realities in proper way? Like in being a sensitive issues like family planning or maternal issue or male involvement in the maternal health mortality. Is it possible without an expertise or having vast training in qualitative research? Is it possible to apply or explore because what we are doing in in-depth interviews or key informant or FGDs or even in survey, it's kind of our human understanding, what level of understanding we can go for. So without epistemological issues, that's how we are, what we are, and why we are adopting in these methods, that should be more emphasized in our research issues, research focus. The topic will define the methods or data collection tools. So we should rethink what. I cannot suggest, I cannot tell this should be the best way or proper way, but we can rethink. We can go for the new strategies for our research. Like mixed method should be the best way to, not only mixed method, there should be the triangulation issues, like only conversation and interviews are not evident, that in either for IDI or for even survey, that need to be cross-checked, that triangulate the experiences, every experiences. Like for my teaching experience, if you ask me that, oh, tell me about your teaching experience in your, then I will share, oh, okay, this I am very happy to teach, and I am very happy to research, doing this kind of research, and I'm dissatisfied the curriculum and the systems and these factors. But what about the male engagement? If you ask me about that, oh, do you accompany your wife during delivery or PNC or birth decisions or birth spacing decisions, birth planning? What can, so every stages, every man should be, not only every man, the family members should be participated in this process. So when we are doing our research about their participation or engagement, then we have to rethink our existing methods, methodologies, data collection techniques, or application of these techniques. So more about and should our training also. So without training, and even in business research and others every research they are adopting, they are mentioning that they are doing in-depth interview, key informant, or FGDs. So how they are doing this? Can they explore the realities? Like you are saying, ask me that one question that oh, I visited one of my relatives' house once, and when I was staying there, my another close friend called me that you need to come emergency to your home, and that is very important to come, and I am come back to my home. So what we are learning from this data, or can we say this is data? If qualitative research, they didn't ask me which relatives, is my friend's home, is my father-in-law's homes, or in my other relative sister's homes, or any what that's not indicated. And who make the call, family members or close friend or other friend, and what kind of emergency, is it family member emergency, what kind of emergency, is it the maternal health, is it the accident or other issue, and how many days I staying there. That issues, that narratives should be explored in depth way. Although many ethnographic research approaches are still applying this, but these should be more effective way. Effective way means I want to that should be the staying more and more, and visiting more and more, and that cross check. Like for one strategy, one experience last time in my lecture I shared that I was working one research among the tea garden workers about their cesarean section decisions. So 2 or 3 interviews, I found that these interviews are not giving me the data deeply that what I am expecting. Then I seated with my research assistant, and then we planned that first we should go to the hospital sections where they conducted the C-sections, and then the clinic manager and the nurse, they shared that they are, and they share about their health issues with them. Then we took the identity, took them for interview, and then visited to them, and then conducted interview, because they are willing to share, and that's why it helped me to conduct. So this can be one strategy. This should not be the whole or the ideal strategy. Last I'm saying, this way we can rethink about our research strategies, our methodologies for our next research in male engagement, male involvement in reproductive, contraceptive, family planning, maternal mortality, and contraceptive use kind of research. So next slide, please. And finally, some recommendations from the past studies I mentioned here: the engaging population, civil society, communities into national policy and decision making, care by skilled health professionals before, during, and after childbirth can save the lives of women and newborns. And there, the social support, educate, information, shared responsibility is very important. Is already these studies, and understanding the role that male partners play in family planning and contraceptive uptake and use is important in preventing unintended pregnancies and improving family planning policy and services, service delivery programs. And we some studies I found that during the COVID-19 pandemics, there are a lot of not lot is more than double the rate of unintended pregnancy increased during this COVID-19. Maybe only for this non-participation of contraceptive use or decisions or male dominance, maybe, and promoting participatory governance, social participation, and accountability should be established among this the population or civil society and the communities and the researchers as well. So these are my presentations. Thank you so much, everyone, for listening me with patience. I don't know what I can share with you might be helpful or not. I thank you so much. Question I will share then.
Okay, it's very interesting. Just now we got a lot of information from Dr. Muhammad Sahminan Mi'ad. For a while, I haven't been able to make a summary of what Dr. Sahminan Mi'ad has presented. But please, from the audience who want to ask or additional information or something else to say, yeah, so that it is clearer or understands of our topic today. Anyone want to ask Dr. Muhammad Sahminan Mi'ad? Please raise your hand. Okay. Miss Husnia Tahta Afwina.
Okay, thank you, Mr. Samsul, for the special topic this day. And thank you for Mr. Sagahan for the topic. This is really interesting topic, I think. from your presentation, I see that the problem of the main issues of the maternal and child and family planning is the lackness of the awareness of the men who that is the responsibility of take care of baby, and then their household is only for women's duty only, I think. And my question is there any policy in Bangladesh or maybe the social norm in Bangladesh that how to being a good husband? Because in Indonesia, we have the program that is the pre-marriage program for a couple who want to be married. We have the school pre-marriage school, and I really shocked for the amount of the mortality birth in Indonesia is still in high number. So with that program, I think it's only decreased a little amount of the mortality. So would you share to us in Bangladesh how to make this amount of number is decreased, and how with the culture there? Thank you so much.
Yeah, thank you. Thank you, Husnia. Unfortunately, in Bangladesh, there is no policy campaigning for male engagement like in Indonesia. Then if there, I searched Director General DG Health, Director General Health, and other documents, and some resource person I also asked before preparing, when I preparing my presentations, if I miss, then they also shared no. After 2011, the national health policy, after that no policy taken for the maternal child health or even male engagement in context of Bangladesh. But still there are some the maternal mortality or child mortality under 5 is reduced in Bangladesh. That some study focus that are very successful. The underlying factors was the trained birth attendant ensuring in the community level. In the community level means every village you will find one community clinic there, and there every it means the small unit of the country, the world that village. There's the trained birth attendants, they refer, and health assistants are in the community clinic, and some NGO programs also. Some the largest world's largest NGOs, they have they have delivery centers even in slum to the rural area. So this NGO and government both participatory program may be the leading cause of successful, not success, still high, but the noticeable success in context of Bangladesh. Thank you so much. Yes, please.
Please unmute, Miss Husnia.
Unmute first.
Yeah.
Unmute.
Husnia, please unmute your microphone.
Okay, I'm sorry because the host is mute me before. With the research of your presentation before, there's some research of and there's a result of your research. The question is there any advocation team that would like to bring the results come to government, or the result is only that result with pure result, or there's any advocation team that could bring the result to the government so it can make any change or make any policy maybe for the increase of the awareness of men to be a good husband. Thank you.
Yeah, you are welcome, and the very good questions. And in Bangladesh, many studies are conducting, like the ICDDRB, International Diarrheal Disease Research Bangladesh, that is the very good research institution. They have separate divisions for maternal child mortality, and they have collaboration with the Ministry of Family Planning, and they have good research, and they already collaborate some policy issues. But it's unfortunate, I said, that the policy, the 2011 National Health Policy, are not advanced or the updated. Maybe some issues already included, but the national policy or the any campaigning like SIAGA are not still introduced for the engaging the male responsibility here in Bangladesh. Thank you. Yeah.
Okay, thank you, Ms. Husnia. Any other questions? Oh, there is question from Mr. Lucas T. Adi from the chat box. Mr. Sakanan.
Yes.
Mr. Sakanan,
yes,
what do you think about early marriage at the age of under 20 years?
Yes.
Whether it contributes to the contribution of maternal and child mortality? How about best practice from Bangladesh? Okay.
Okay. The marriage age is already according to the government law, is for girl it should be the 18 in context of Bangladesh, and for male husband should be 21. So this is our national health policy. So but still many study already identified that, especially during this COVID-19 pandemic, there's economic crisis, huge number of early marriage conducted in context of Bangladesh. So in the early marriage, like, means it's maybe different in country context. When we are talking about this, the age bar is either 18 or 20, is that replies that it's not the proper time for the female to conceive or to carry the newborn for the next generation. Because if we are want to healthy baby, but we are not considering the mother's health, so how we can expect the healthy family or healthy society? So I think in Bangladesh also there are some best practice in law. There is the 18 years, but still it's highly endangered in number are doing their because there are some social issues also, because in context of Bangladesh, the parents are not economically solvent. They want to give their daughter to marry, and they want to release their responsibility from their and the family planning method is not still effective. You will find many families, they have more than 2, 3, 4, 5 children. So especially in the low income group, so they are not best practicing this one. So and this is the reality, that we have the policy, but we have not the best implementation. We cannot give them marry within this age bar, but still they are practicing a lot. That is really danger sign for our next generation, not good health. And this also include increasing the maternal mortality and under 5 mortality rate. Yes. Thank you so much.
Okay, Mr. Husnia, thank you very much. Dr. Zakanan, it's related to the question from Ida. Yeah, she WhatsApp me. How to reduce infant mortality by preventing early marriage, considering that in some areas of our country there are still cases of early marriage, even though counseling to delay the age of marriage is often promoted by health promoter. Yeah, it's related to Mr. Lucas' question.
Yes, sorry, again, please.
Yeah.
Lucas present the regional disparities. You want to see the early
Yeah.
marriage?
Mr. Lucas married. No. It's
how to
the
reduce
question about
yes,
how to reduce infant mortality by preventing early marriage.
yes.
Early marriage, considering that some areas of our country there are still cases of early marriage. Even though counseling to delay the age of marriage is often promoted by health promoters.
Okay. Thank you. If I understand this, the early marriage still in many countries. So in this is really contributing to the maternal and under 5 or newborn mortality, because the mother's health is not fit, and then their newborn health would be the safe. And there are some counseling to visit with the male involvement to counsel, but still cannot as the early marriage, the girl, the mother is not fit for the reproduction for the baby. So this really danger signs, because although they visited some healthcare facility center or the counseling or the other health, and even to the male partner for the nutrition, behavior or other things, but they have still risk for giving birth. This should be for the mother and risk for the newborn. And first we have to work on reducing the early marriage. If we cannot prevent this one, then we can go for the birth planning. Okay, the social reality or social norms might cannot prevent the early marriage, but those who are already early marriage, then we can work for to birth planning. Then which stage or which age should be the best for conceiving or they are getting the children next year. So this way we can counseling more, and that will reduce health maternal mortality. Thank you.
Yeah. Okay. Thank you very much, Dr. Muhammad Sakanamia. Any other question from the audience?
Rifka.
Oh, Miss Rifka. Please, Miss Rifka, open your microphone.
Okay. Thank you for the opportunity. Assalamualaikum, Dr. Mia and all audience. I'm Rifka from Undip's Health Promotion Master Student. If I may ask, and maybe my question is a little outside of what was said. The problem is, as we all know, that it has become a culture for women to take care of their pregnancies, and men have the role of earning a living for this process. But in reality, there are still conflicts with this problem, especially if there are abnormalities in the pregnancy process, even after the baby is born, if there are abnormalities in the baby being born, or even having a difficult pregnancy or birth. It seems that the one to blame is the woman. Then how do doctors respond as men to this phenomenon, or basic on your country especially? Thank you before Mr. Mia.
Yeah. Okay, thank you, Rifka. This is culture because it's the natural process of the mother's pregnancies. So this is the natural process, but the natural process is when is complicated or complex when that social issues are arise there. So male engagement might be the process to there, but your question is that conflict when abnormalities. Our reproductive technologies, it's not only for the abnormalities after giving birth, the abnormal side. It's the reproductive technologies like the ultrasound. Even in my last studies, the C-section, cesarean section decisions, I found there some data that when the parents-in-law or husband even, they can identify the sex of the newborn, the infant, upcoming infant, this lead to the cesarean section. If the boy, then they go for cesarean section. They didn't wait for the normal delivery. They don't want to wait for the normal delivery if they any complications. And some study there I found when I review study, there many study already identified that when they found that in Indian context, you will find that the girl, then they go for abortion. And this is the social context of the country. And when the abnormalities that not only for abnormalities, in case of the death, the newborn death, that blame goes for the mother. It's the responsibility only for the mother. So this is our complex realities in our society, and abnormality is maybe the biological issues, not the social, not the mother's not the mother's single issue for becoming the abnormal child. So here this is very real complex to minimize this kind of social problems, because we cannot say why the abnormal children, but the responsibility when we are engaging male for not only for the health service, visiting to the health service provider, health services, or preparing the other issues, or to the mental support, emotional support, we should be work on this way, what are the realities can happen, that then this can be the male or the new one should be sex, should be male or female, that should be even not maybe die newborn, or can the abnormalities. So this is the natural process. We cannot prevent. Not only natural process, maybe some can early stage some medical updated information or medical facilities, they can treat it. That is the other issues. For our public health issues, that should not. We can work for this. What are the realities can come? So it's maybe male or female. It can be died. It can be abnormal. But so this should be normal. It's not the mother's responsibility only. It's both. Okay, because we cannot know which one the real option. And you know that in Bangladesh, one study already identified, maybe in other countries also, that those who cannot conceive, the mother, maybe the problem for the husband also, but the blame goes for the mother. So stigma, social stigma. So mother, these women cannot conceive. So I studied, maybe the biological test identified the husband's fault, but the result blame goes for the mother only. Thank you so much. Maybe.
Okay. Dr. Sakanan, there are two questions via the chat box from Intan Dewi and Basaria. Ms. Intan Dewi, would you be willing to ask orally directly to Dr. Sakanan Mia? Mr. Sakanan Mia could read and answer your question. Oh, there are questions from Ms. Ratu Matahari. Also, Miss Ratu Matahari, okay? Would you be willing to ask orally directly? Mbak Ratu Matahari. Or still problem in the microphone. Okay. Mr. Sakanan, would you please answer the Intan Dewi question from the chat box?
Yes, I already seen here. She asked question about the EPMM principles there, that the girls, women, and the communities empowerment. Maybe the communities, maybe I don't know what they understand. Maybe communities, not only the women, single mother, maybe communities, all the family members, all the male, including male, should be empowered. So these men, without men empowered, the only the women or girl cannot be succeed there. And is there any rejection to vaccine and contraceptive in Bangladesh? Yes, still even in the COVID-19 vaccine, the contraceptive issues, many people still not vaccinated. They try to avoid this vaccine. There's a lot of misinformation, misunderstanding are there. And about the contraceptive use, there is the male dominance, and this is the women responsibility. They should take the birth pill only. Many study already identified, not the male responsibility. Although these are changing trends among the educated group. One study they identified educated group, those are husband supporting. They go for contraceptive use, like condoms, but not all. Still there are rejection, including the child maternal vaccine and even the contraceptive. But for the basic vaccines for the children, like polio, diphtheria, that kind of vaccine is the very successful rate in Bangladesh. It's role model. There is no polio. You cannot find in Bangladesh last 2 decades. So thank you so much. Another maybe Basaria.
For the next question,
as a practitioner in rural area, we found that women couldn't decide by herself for family planning method, Pasca maternal. It often decided by her husband and her and didn't allow. What do you think about that? How we as a practitioner give suggestion to them? So the male engagement, your Siaga campaign would be the best way forward to counsel them that this responsibility is not only for women. This responsibility is both, and there are some family planning method, because these are the birth control pill. They have many countries already identified that they have reactions, medicine reactions. They have some side effects also, allergic and other issues. So that birth control pill or kind of the injections or the other surgery that are not good fitted or helpful for women, but maybe some side effects for the women body. If we can counsel them that if your wife cannot adopt with these medicines or the birth control pill or that method, then why not you? It's not only for your responsibility. And as a husband, you can go for the injections, you can go for the condom use, and we can counsel this way. Maybe that would be the way forward for this. Thank you.
Then Miss Ratu Matahari, would you please
Yes, Mr.
As
Samson.
okay.
Yes, could you hear me?
Okay, clearly.
Okay, yes, thank you, Mr. Sagan, for the interesting topic. When we talk about the men involvement into reproductive health, I think it's very challenging, especially when we talk it in terms of the patriarchal community. So the dominancy of the male to encounter the women, and based on several studies in Bangladesh that I ever uh, read before, is revealed also the mortality and lack of the antenatal care access. It's caused by intimate partner violence among women by their spouse. So my question is, what kind of the activities or program from Bangladesh government or from researcher there, how to empower women and also men to reducing the number of domestic violence in terms of the antenatal care or reproductive health issues. Thank you.
You're welcome, and very good questions. In Bangladesh context, you already noticed that the violence still lot, and there for incorporating the health issues, there is no policy. From my knowledge, I don't find any that kind of policy issues to reducing the health issues, including the violence. But from Bangladesh government, there the domestic violence against the legal issues. If any women got the domestic violence or by the intimate partner or even the other family members, if she complained to the near police station, the husband or even the other family member, mother-in-law, father-in-law, would be arrested soon. So this, as you know, the Prime Minister last 3 decades from 1990 are women. The Prime Minister Begum Khaleda Zia and the Prime Minister Sheikh Hasina. So these two ladies are mostly focused on the legal issues for favoring the female. But still there are a lot of violence, because this violence is not only cannot prevent by implementing the legal issues. This should be the social issues, because the insecurity, when you will find that they are acknowledging or reporting some the intimate partner violence, domestic violence, but they did not go for the separation for the insecurity. This is social issues, because the single motherhood is another challenge, or single going to the second marriage is another social stigma in context of Bangladesh. So the family members try to compromise with the husband's family, those who are already violated. So we are giving the double burden to the girl or the female. So this is the cruel reality in context of Bangladesh. Although the scenario is changing, you will find that those who are working and who are educated, they are the divorce rate is in Dhaka city capital. You will find the study that is higher than any other part of the province, like a division in Bangladesh. So this is changing, but still have to go along, because the rural area, even in urban slums, you will find a lot of intimate partner violence, domestic violence, but they are not reporting. Reporting means to the police station, or they are not going for the separation. So this is the complex realities in context of Bangladesh, I think. Can I explain?
Yes, it's very clear. Thank you.
Okay, thank you so much.
Yeah. For the next question from Mr. Apani. Okay, please, Mr. Apani. Okay.
Thank you very much, the presenter, for the presentation. So I'm trying to get this picture. I'm from Nigeria. Okay, Nigeria has one of the highest maternal deaths in the world. So maternal health is a very poor issue in Nigeria. So that's one of the reasons why I also had to join this session, seeing also men. So I'm trying to compare to see the situation of Bangladesh and Nigeria. In Bangladesh, do women require permission of the man before they can go to hospital for antenatal care or postnatal care or to deliver in a health facility or to go and get family planning contraception? Does the man have to give the woman the permission to go, or the woman have the power to go on her own? Because this is where the role of men comes into play. If the woman lacks decision-making powers on herself, she has to rely on the man, then that is where the man is very, very important. If the woman has a decision-making power to go on her own without the man, then fine, it makes things easier. She knows when she needs it. She knows when she needs to go for antenatal when she's pregnant, so she can go without the man. But if she must take the permission of the man, then you can see that the man is very, very critical. And in this case, what the policymakers need to do is to create a special awareness for the men to understand that why the woman need to go to hospital for antenatal care. Let me share experience with Nigeria. A typical rural man does not think that antenatal care is supposed to be a preventive way, for maternal mortality or child mortality. He thinks if the woman is not feeling sick, then she doesn't have to go to hospital for antenatal care until she feels sick before she can go. So if the woman says, I want to go for antenatal care, I'm due, he says, you are not sick, so you are not going, and she has no power to go because he is the one that have the power. Like Ratu talked about patriarchal society. It is a patriarchal society. The man is the head of the family. He feeds the family, he takes decision, both on reproduction. So we look at it within that context. Is it the same thing in Bangladesh? Do men have the final say? If they do find a final say, then policymakers must also design policies that will make the man to understand that the woman needs to go to hospital. And also the government, I don't know if it is there, should also make it in such a way that when the woman needs to be in the hospital for delivery, her husband should be there. And if it is on a working day, it will not be a problem for him to leave his office work and be in the hospital with the wife who wants to deliver. But if it's a problem for the man not to go to work and then be in the hospital, it will be a problem in his office. Definitely the man will go to the office and leave the woman to go to the hospital alone. And so these are some of the challenges that also men face in that regard. For instance, in Nigeria now, we have had the paternity leave has been approved for men, so that at the point that the woman is getting to give birth, the man will take the paternity leave and be with the woman. She delivers, you stay with her for the 2 weeks after delivery. That will ensure the health of the child too, because it impacts on the health of the child at that critical period. So these are areas that the policymakers need to look at. How to bring about men to participate more in this process so that it will enhance the health of women and the babies, and then bring about a reduction in this child mortality and maternal mortality. So I don't know, just sharing the context of how, I don't know how it is in Bangladesh, or these kind of challenges are there in the Bangladesh society or not. Thank you very much.
Yeah, you're welcome. And you already shared some issues in your country, Nigeria, and some Bangladesh context. Some issues are almost same in context of rural areas. Still, mothers are not aware about the ANC number of visits, but still in Bangladesh the situation is improved. The case of reducing the MMR or under 5 mortality might be the cause of the higher number of C-section visiting to the hospitals, facility centers. Although there are some health workforce shortage in government hospitals, but there are a lot of private clinics are mushrooming in Bangladesh. You will find. So these private clinic and in already Bangladesh government last year introduces another campaign, anti-cesarean section, stop the unnecessary cesarean section. So this is the higher in any other countries of the Bangladesh. So the visiting to the health facility center or for going for the contraceptive by the mother decision, I'm sorry that I don't have no idea or any research study. I didn't study about this, the consent, about either husband's consent or they take or not. But the UN Women report that this in Bangladesh there are 37%. I say the Southeast Asian UN Women report 2015, they identified the Southeast Asian women cannot visit alone to the health facility center. It's 47%. India, I forget. In Bangladesh, 37%. Nepal, around 37%. So these are the reality. They cannot visit alone. So maybe they need the permission. I'm not sure, but this might be the one reality. And you already said that policy making in parental leave is in Bangladesh also they have leave when the becoming the delivery, the father get 7 days paternal leave during the delivery. So still for supporting to the mother, for supporting to the present, but you will not find. You can search the study. I didn't find that any study already identified that husbands are presenting or even husbands are allowing to giving the delivery in present of the delivery. It's not allowed into the cesarean OT room, operation theater room, or even to the for normal delivery in at home. This is not still unaddressed. So thank you so much.
Yeah. Any other question or comment? Okay. Dr. Sakanan, here is a question from Mrs. Dayani. Yeah. I will read a question. Pak Samsul, Mr. Samsul, please ask the speaker. Yeah. Engaging men is very interesting, especially for husbands. What kind of community empowerment that, in your opinion, is the best or the most efficient to do this? In the first question from Ms. Diani, and then the second, how is the male's participation in family planning methods in Bangladesh? Are there any rejection of family planning and Bangladeshi? Yeah.
Okay, thank you. First,
From Ms. Dayani. Yeah, thank you, Ms. Dayani.
Thank you, Ms. Dayani. I would like to answer the second question first. About the rejection about family planning. I already shared that still the scenario of the Bangladesh population that still that represents the rejection, maybe because the still not single although government have the policy to 2 children, and even single children are best encouraging, but still in Bangladesh you will find that most of the family have more than 2 children, even 4, 5, 6. Even in my university, in my colleague, you will find those who are professor, they have more than 3 children. So this is not the related with the contraception use. This is the decision, maybe both of the family, because maybe the family's security, maybe the other social they are satisfied with this, having this more children, because they maybe some happiness indicated, other things might be there. I don't know about this issue, but still there some study found that the family planning method is still there are rejection are still working there. And what kind of community involvement means that in case of the urban areas, the education, they are already some they have responsibility, or they are already known about their health, their newborn health and mother health. They are aware. But for the rural areas, especially rural and the slums, there should be should address the gatekeepers of the society, like village, like every village have mosque, several mosques, and the religious leaders are the best one to to encourage or to counsel the family member to use the contraceptive, because accepting the contraceptive use sometimes goes the Muslim religious against the Muslim religions. Still in Bangladesh, they consider in the village that if sons come or children comes, the food will feed by the Allah. So I should not go for that one. So this kind of beliefs are still working here. So if we can engage the religious leaders of the mosques and the school teachers, those who are still influential persons in the village, and the village leaders, some village leaders are also, if we can engage them, this male engagement into the maternal health, reproductive health, and even to the contraception use would be successful in context of Bangladesh, or maybe in other contexts. Thank you so much.
Then Dr. Sakanan, it's a question from Miss Ayu. Yeah, Miss Ayu. Most Indonesian are patriarchy, and it affects the quality of health services, especially when it comes to the health-seeking behavior. Some pregnant women died due to the late decision of their husband to take them to the health facilities. What about in Bangladesh? Does this situation happen as well?
Oh, same. The Indonesia and Bangladesh context, society is patriarchy. Similar, yeah. Same. Male dominance, male decisions are influenced. Not only male, even the family household head, like father-in-law, they decide. Even in mother-in-law, in absence of the father-in-law, they decided whether they will visit to the medical hospital center or other services. And one study already identified that the pregnant mother decided to prefer to visit their own mother's house, like mother's house, not staying to the husband's parent house. So this is the patriarchy norms. Patriarchy, maybe the wife are not free or cannot express their demands or other needs to the husband's mothers or within the family. So this is the reality in Bangladesh as well. So this family member should be involved in our programs, implementing programs to that they will support, they will they will recall the number of visits. Oh, your date is that day, so let's go for the visits for the ANC, and this way can be helpful, I think. Thank you so much.
Okay, I think it's, yeah, there is no question from the chat box or question from my WhatsApp. Okay, ladies and gentlemen, is there any question again to Dr. Muhammad Syahkanan Mia? Nggak ada? Cukup ya? Okay. Thank you, Ms. Dr. Muhammad Syahkanan Mia. Ladies and gentlemen, we have learned enough about today's topic with Dr. Muhammad Syahkanan Mia. I hope what we learned today will benefit all of us, our interest in public health. And then on this occasion, Ms. Faiza Fadila will present a resume. Hopefully it will help our learning process about the role of men in maternal child health and family planning. Please, Ms. Faiza Fadila, convey the results of the resume you got.
Thank you for the opportunity, Mr. Samsul.
Speak up. Okay,
Thank you for the opportunity, Mr. Samsul. I would like to convey the resume of today's discussion. So, due to the high number of sorry for the inconvenience. So, due to the high number of maternal and child mortality rate, there are strategies for reducing them, such as Millennium Development Goals, Sustainable Development Goals, ending preventable maternal mortality that consists of 5 coverage targets towards advancing maternity health, and 10 milestones to advance the ending preventable maternal mortality. There are challenges of involving men in maternal child health and family planning consists of lackness of the understandable about maternal child health and family planning, social culture barriers, traditional gender norms, and the absence of due to overcome the challenge of involving men in maternal child health and family planning. There are strategic planning guide that consists of 4 steps. There are define the behavioral aim of your initiative. And the second step is assessments and boys' knowledge and attitudes related to reproduction and contraception. The third step is assess how gender norms affect male engagement in family planning. And last, identify programming approaches that engage men and boys. And there are also recommendations that consist of engaging the population, civil society, and communities in national policy and decision making, care by skilled health professionals before, during, and after childbirth that can save the life of women and newborns, social support, adequate information, and shared responsibility, understanding the role that make partners play in family planning, uptake and use in important and preventing unwanted pregnancies, and improving family planning policy and service delivery programs, and last but not least, promoting participatory governance, social participating, and accountability. That's the resume for today's discussion. Thank you.
Okay, thank you, Ms. Faiza Fadila. Yeah, we are already in the end of the event. For the audience, would you please open your cam? We will take a picture together to cut the picture. Please on cam your computer. We will take a picture. Ready? Yeah. 1, 2, 3. The second. 1, 2, 3. Yeah. The last. 1, 2, 3. Okay. Thank you for all participation here. We are already in the end of the event. Is there any message or closing statement from Dr. Muhammad Syahkanan Mi'ah that you would like to tell to us, please?
Okay. Thank you so much, everyone. Thank you so much for the Faculty of Public Health, University of Diponegoro, and this issue is really important. I think for not only a policy making issue, it's for the implementation, because many countries can have take the or adopted the policy, but the main problems are doing implementation. When they are doing implementation, then the community might not be accepted this, or the way the implementer are implementing the process, the way are not the favorable or friendly with the community. So before implementing, first we should go for research for priority, that how or what are the existing norms or social behaviors are existing there, or are context considering there. Then if we explore the realities of the behavior or particular society or context, then we can go for the planning for the implementation, the policy. So this way would be the successful implementation, policy implementation, that would contribute to the result for the reducing maternal mortality and ensuring the good health and well-being for the mother and children and for all. Thank you so much.
Okay. Thank you, Dr. Muhammad Saknamiah. And ladies and gentlemen, thank you for all of your participation in today's seminar. Special occasion to Dr. Muhammad Saknamiah. Till we meet again to the next seminar, and we hope continue with the next program or seminar, especially to Dr. Muhammad Saknamiah. If you have time, we can continue our seminar with the other topics.
Yes, inshallah, because it's my
Inshallah,
I will be privileged if I can share, because this process I can also learn from you all, and this between also this is exchanging also. Thank you so much everyone, and inshallah we'll meet again. Thank you everyone, thank you so much. I know the terima kasih word. My friend Wati was Anisat Wati was there, and Nur Rahma. When I doing my PhD, 4 of my friends were from Indonesia, so I some few. So thank you so much everyone, and thank you. Assalamualaikum.
Okay, thank you very much, Dr. Muhammad Saknamiah. Let us close this event by saying Alhamdulillah together. Alhamdulillahirabbil alamin. Assalamualaikum warahmatullahi wabarakatuh. Salam sehat untuk semuanya. Sampai ketemu lagi. Till we meet again.
Assalamualaikum everyone.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Mr. Sakanan.
You're welcome. Assalamualaikum.